Hello and welcome to this IMV Imaging Journal Club recording. In this presentation, I will be presenting and discussing the methods, results and conclusions of several relevant recent studies which I have critically evaluated in order to answer the question, what is new in equine foot radiography or radiology? Further discussion of these results and conclusions, our personal experiences and the potential clinical and practical application of scientific knowledge to our everyday work is where we would like you to get involved. At the end of this presentation, there will be the opportunity for you to submit your comments, thoughts or questions to us. These will be used anonymously for the audience-led discussion which will be taking place this Thursday evening. You will receive an invitation to this event in the follow-up email, and we hope that you'll be able to join us. By attending the audience-led discussion, in addition to watching this presentation, you will receive an attendance certificate that can be used to support your UK CPD requirements. So for this journal club, I wanted to ask the question, what are the recent scientific advances in practical radiography or radiology of the equine foot? And off the back of that, is there anything that we should be doing differently in our everyday clinical practice? So I developed these listed search terms and inputted them into the PubMed search engine. And I did apply a couple of filters, so I only wanted to critically assess any papers published in the past 5 years. Of the 105 papers that were pulled up, I narrowed these down into 13 potentially useful studies. Based upon the topics covered by these studies, I divided them into these 4 topic groups. So we had 3 papers, each looking at views and patient positioning or preparation. So these are pertaining mainly to radiography. And we had interpretation, so specifically looking at measurements on radiographs, and also 2 studies looking at the relationship between hoof conformation and lameness in the hind limbs. Now, I thought 13 papers was far too much to be able to cover in one session, and so I've divided it into part 1, which will look at radiography, and that's what we're doing today. And part 2, which will be available shortly thereafter, will be looking at the topics pertaining to radiology of the foot. So this first paper, which is titled Additional Palmaroproximal Palmarodistal Oblique Radiographic Projections, which are also known as skyline and navicular views, improve diagnostic accuracy of detection and characterization of equine flexor cortical lysis. So they're referring to the flexor cortex or the palmar compact bone of the navicular bone. And this is potentially a very important location of clinically significant lesions. Lesions in this region typically are best evaluated using MRI, and that is generally the clinical gold standard diagnostic tool. As well as actual erosive lesions, we can see irregularity or thickening of the palmar compact bone. And in addition to this, concurrently, it's not unusual to see dorsal border fibrillation of the deep digital flexor tendon, and there is a potential for adhesions to be present between the 2 structures. Now, erosive lesions can sometimes be seen radiographically, however, their interpretation can be challenging. And so the aims of this study was to ask the question, if we used an additional shallower skyline view in addition to a standard angled skyline view, will that improve the diagnostic accuracy? And also, what effect does interpreter experience have? So this was a prospective study. They employed 31 horses, of which 30 were quarter horses, which yielded 36 limbs. Half of them were control limbs and half were cases, so half of the limbs did have erosive lesions. In all limbs, a standard radiographic projection was acquired, and they used an angle between 55 to 65 degrees. In addition, a shallower radiograph was acquired, and this was between 35 to 45 degrees. For interpretation, they had 4 groups of equine vets at different experience levels. So we had radiologists, who are diplomats, imaging residents, experienced equine vets, and 4th-year veterinary students. Each observer was given a survey, and in a randomized order, they were presented with, for each horse, both a single standard radiographic view to evaluate, but also a combination of the standard and the shallow radiograph to evaluate. And based on either the single versus the 2 radiographs, they had to answer the question, do you think a flexor cortex erosion is present? So that was a binary yes/no answer. And they also had to grade the severity on a 5-point scale, so with 0 being normal or no erosion present, and 4 being severe. The gold standard by which each horse was categorized as either being a case or control, and against which the observer's grading was assessed, was a radiographic diagnosis made by the 5 radiologists who were also the observers, in combination with 1 other radiologist. And there had to be a consensus agreement of at least 4 out of the 6 radiologists in order to be able to categorize each foot as being a case or a control. So the results in brief: of the 18 case limbs, 10 had moderate erosions, 7 had severe erosions, and 1 had a mild erosion. Again, this was determined by consensus agreement by the radiologists. The presence of erosions was the sensitivity for identification of them significantly increased for all of the 4 groups when the 2 views were used versus only the 1 standard view. There were trends for increased accuracy but decreased specificity with multiple or 2 views. However, both of these were non-significant. For the severity grading, there was a significant increase in accuracy for all observers when they were combined, but not for individual experience groups. And this may well have been that when combined, the results from the radiologists, who were also the gold standard, were being included in the test population. In addition to those briefly alluded to, this study does have some pretty major limitations. So the gold standard, I think, was inappropriate. MRI or histology would have been a much more appropriate gold standard for comparison. We know that there are lesions or erosive lesions that can be detected on MRI and also gross pathology or histology that aren't radiographically visible. And so it is possible that some of the control horses did actually have erosive lesions that simply weren't recognized based on the gold standard of radiography. The gold standard data was also included in the test data. So essentially the authors were testing the data against itself, which should not happen in a scientific study. And so making any conclusions that multiple views or 2 views increase the diagnostic accuracy of radiography based upon this analysis is inappropriate and pretty weak. As I said, there was potential for a crossover between case and control feet. So they use multiple feet from or 2 feet from a single horse, obviously multiple times. And it would be unusual for pathology in this region to be completely unilateral. It can be asymmetrical, worse in one limb than the other, but it would be fairly unusual to have a horse that has a genuine control limb and a genuine case limb. Further, the design of the study didn't necessarily test the difference between 1 versus 2 views, and this is what the study aimed to do. And this is because the shallow view alone wasn't independently assessed. And so we cannot make any conclusions that 2 views are better than 1 based upon this study, because any differences between 2 versus 1 view could equally reflect the fact that the shallow view may have been more diagnostic than the standard view. So it's not necessarily the combination of 2, it may simply have been that the shallow view provided more information. And this is potentially logical because a shallower skyline view would skyline the distal aspect of the navicular bone better than a standard view or a more steep view. And it is the very distal aspect, or the distal 1/3 to 1/2 of the navicular bone, that is a predilection site for erosive lesions. It did provide, however, some evidence for increased sensitivity of 2 views versus 1. However, that does not necessarily mean that we should be taking multiple views routinely. As previously mentioned, it could equally highlight the importance of the choice of angle, potentially depending upon foot conformation. So interestingly, in this study, the standard view was much steeper than that which would be considered a standard skyline angle in the UK. So in the UK, standard skyline views would be acquired at 45 degrees, which, based on this study, would have been classed as a shallow view. However, the population in this study was very limited, and most of them were quarter horses, which do tend to have quite upright pasterns and hooves, and therefore a standard view for a quarter horse may well be required to be steeper in comparison to the standard view required for a thoroughbred or warm blood. So a standard view is, the aim of it is to have the beam perpendicular, or sorry, parallel to the palmar compact bone of the navicular bone, and so conformation does potentially play a role in the ideal angle of a skyline view. And again, erosive lesions, especially if they're mild ones, can be seen quite frequently on MRI in the absence of any radiological abnormalities. In addition to this being my personal experience, it has also been mentioned in 2 studies, which I will reference at the end. This comment, it could also explain why the majority of lesions radiographically were graded as moderate or severe, and there's only one case horse that had a mild erosive lesion, and this may well have been simply because only moderate or severe erosive lesions can be seen radiographically, and so some of the milder lesions may have been missed, and therefore some of the control horses in this study may actually have been cases. So despite the limitations, there are some potentially interesting results that I think are worth discussing. I think it potentially highlights the importance of angle choice. Shallower angles logically skyline the distal aspect of the navicular bone better. And so if we are suspicious of an erosive lesion or want to evaluate the distal aspect of the palmar compact bone, acquiring a shallow angle may well be of some clinical use. However, there is no evidence to support that the acquisition of multiple skyline views is any better than one well-positioned skyline view. Further, the sensitivities of radiography reported have to be inaccurate because they were tested against an inappropriate gold standard. And we have to ask the question, does radiography only potentially identify moderate or severe cases of erosive lesions? I think it's quite likely that radiography does miss the vast majority of mild lesions. So further investigation is certainly required, including an individual assessment of different angles rather than multiple versus one view, but also relating this to hoof conformation and also testing against a gold standard of either MRI and or histology or gross pathology would be much more appropriate and would be absolutely required before we can make any conclusions or strong conclusions based on whether two views are better than one. In this second paper, they looked at technical innovation changes, standard radiographic protocols in veterinary medicine. They asked the question, is it necessary to obtain two dorsoproximal palmarodistal oblique views of the equine foot when using computerized radiography systems? So in a standard set of foot radiographs, we would typically acquire two dorsoproximal palmarodistal oblique views. So these are upright views, usually at two different angles. So the upright pedal, which is typically used to assess the distal phalanx, and the upright navicular, which is acquired usually at a slightly different angle, slightly different collimation, centering and tighter collimation in order to evaluate the navicular bone more specifically. So with the relatively recent advances in post-processing technology in digital systems, whether that's digital or computed radiography systems, are two views still required? So they used 15 horses, both front feet, which gave them 30 front feet. And for each horse or foot, they acquired one upright pedal view, which they subsequently manipulated to optimize viewing for the navicular bone, and they took a separate upright navicular view. There were 4 observers of various different backgrounds, and they were asked to grade the image quality on subjectively based on quite a basic grading system. So 1 to 3 grading, was it 1 textbook quality, 2 adequate, or 3 non-diagnostic? So for the results, when the quality scores for all of these observers were combined, there was actually no difference in overall score quality scores. There was also no significant difference in quality scores within each observer between the one modified upright pedal and the navicular view, and the agreement amongst the observers was good. For comments, they commented that poor quality, so when they graded it as grade 3, as non-diagnostic quality, this was as a result of poor contrast in 16 of the modified upright views and 13 of the navicular views. So roughly similar between the two groups. And they also mentioned that poor quality because the distal border of the navicular bone was superimposed over the distal interphalangeal joint was identified or was not was identified in 4 navicular views. There were some limitations to this study. The authors did discuss this, that they did not actually assess lesion detection. They only used a very general quality score to evaluate the difference between the two views. And this is an important point, because when it comes to diagnostic quality of radiographs, what it often boils down to is we want to know that the quality of our radiographs is good enough to accurately, or allow us to accurately identify or differentiate between pathology and normal findings. And so because this study did not use any horses with pathology, we cannot comment on the relative diagnostic accuracy of the two views. They were simply looking at a very general image quality score. The observers, further, they didn't include any imaging specialists, so no diplomats of diagnostic imaging, and there was only one imaging resident, and that may have produced some spurious results. Other comments, they in the paper didn't specify whether a different angle was used for each of the views. So as I said, usually between the upright pedal and the upright navicular view, as well as having different centering and collimation, usually each would be acquired at a slightly different angle. And so we do not know, based on this study, whether they used different angles or not. So the study may have been only assessing the use of different exposure, centering and collimation versus simply doing post-processing on an existing view. And I would question whether the justification for using two views lies in the use of using two different angles. Because I find that having two images acquired at different angles can be very useful for distinguishing between artifacts, which are very common in foot radiography, and pathology. I've just included these two radiographs here just to demonstrate what I'm alluding to. So the image on the left is an upright pedal, which I have cropped to show just the navicular bone. And on the right is an upright navicular image. Because it's been acquired at a slightly steeper angle, the navicular bone is superimposed more towards the middle, or towards the middle to distal one half of the middle phalanx, which is appropriate for an upright navicular view. And if we assess the distal border, in the navicular view, we can see that it is quite irregular, and also there are three relatively quite large fragments of the distal border of the navicular bone. Now, just looking at the upright pedal image, which is cropped, it's because the superimposition of the distal border of the navicular bone almost with the distal interphalangeal joint, it's very hard to visualize, or in fact almost impossible to visualize and make a diagnosis of fragmentation of the distal border of the navicular bone. So I would question, therefore, and this is the reason why I said, whether the use of two different angles is one of the important differences between these two views, rather than just centering, collimation and exposure factors. So I think before any change is implemented, certainly again more research would be required. We would need a much larger population of horses, which would have to include a wide range of navicular bone pathology, and we would have to assess the importance of acquiring two radiographs at a different angle in addition to what they evaluated in this study. In this final study on views, I must say that I may have a little bit of bias, because whilst I could probably masquerade as not being Laura Jones, now being called Laura Quiney, that was actually my maiden name. So this is a study that I was involved in several years ago, but it did come up in my search, and I think it's relevant to discuss it. So it was a broad study in which we tried to document the radiographic appearance of ossified ungular cartilages, or side bone, and correlate that with clinical significance. As part of this study, we wanted to evaluate the usefulness of flexed oblique views in comparison with other views for the detection of fractures of ossified ungular cartilages. So this was a retrospective study, and we included all horses which underwent a full foot radiography over a time period between 2005 and 2012, which had at least grade 2 ossification. To assess our ability to identify fractures and also separate centres of ossification, we compared lateral medial, dorsal palmar and upright pedal views with flexed oblique views. So we identified horses with radiolucent lines in 42 limbs. Fractures were confirmed to be present in 36 of those horses. The further 7 were potentially either non-union fractures or trauma at a junction between a separate centre of ossification, which was in close apposition to ossification from the base. So I've just discounted those 7 and we'll just look at the 36 which definitely had fractures. So the sensitivity for identifying fractures in the flexed oblique view was 100%. In a dorsal palmar view, that went down quite drastically to only 50%. Similarly, an upright pedal, just over 45%, and in lateral medial views, only 38% of fractures could be identified. Importantly, about 1/4 of horses with fractures, which were clinically significant, were only seen in the respective flexed oblique view. And here we have some images. So the image on the left, we have, this is probably just about within a grade 4 ossification of the lateral ungular cartilage of this foot. And we can see here there's a ill-defined radiolucent zone here with an adjacent area of increased radiopacity. So it's hard to tell based on this view alone whether this is a fracture with adjacent osseous reaction or a separate centre of ossification or something else. This is the respective flexed oblique view for that same foot. And we can see now much more clearly that these changes that we notice on the DP view are in fact a result of the presence of a separate centre of ossification with some increased densification in that region rather than it being a fracture. Similarly, I put this image in. We identified some abnormal shapes of ossified ungular cartilages, including this tree or bulbous shape. And the presence of this shape was significantly associated with cartilages which had modelling or adaptive changes which were clinically significant. Again, this shape was only identified in the respective flexed oblique view. Some limitations, we did only consider pathology related to ossified ungular cartilages. Not all horses have ossified ungular cartilages, and therefore does this study justify the extra time, the additional radiation exposure, and also the cost of using these additional views in a standard protocol? I mean, probably not. I will comment that in my personal experience, I find flex obliques are a very useful view to include in a standard protocol. Personally, I wouldn't be without them. And certainly, if there are ossified ungular cartilage, I think it's essential to include these flex oblique views. There was also another study in which oblique, which is this image at the bottom, or flex oblique images at the top, are also more sensitive for distal phalanx palmar process fractures. But I would love to know what your thoughts are on this, especially that I'm probably a little bit biased because it was actually, like I say, my study. So moving on, this group looked at whether a unipodal stance influences the radiographic evaluation of foot balance in horses. So a bit of background. Raising the contralateral limb is sometimes performed as a method of restraint with foot radiographs, especially if the horse is relatively well behaved and perhaps just radiographs, a lateral medial and a dorsal palmar view are being acquired to assess foot balance. And the question is, does doing this affect the assessment of mediolateral and sagittal balance assessment? So their methods in brief, they had 7 horses and they used the front feet of both of them, so that gave 14 feet, and they were comparing pre-test versus post-test in a prospective study. So they acquired dorsal palmar and lateral medial radiographs with the horse in a bipodal stance. So the feet were raised on blocks and the horse was evenly weight bearing. And they also did the same with the contralateral non-radiograph limb being lifted to simulate that method of restraint. They had predefined measurements, and these were all performed 3 times by one assessor who was an imaging resident. So when evaluating lateral medial images, in comparison with a bipodal stance, having a horse with a unipodal stance, or the limb raised, led to a significant increase in joint flexion of the distal interphalangeal joint and a significant increase in the deep digital flexor tendon angle, which is the angle that the deep digital flexor tendon takes as it passes around the back of the navicular bone. There was no significant change in the joint space of the distal interphalangeal joint, and they commented that there was likely extension of the metacarpal phalangeal or fetlock joint. However, this was not measured as part of the study. In a dorsal palmar image, having the horse weight bearing only on the radiograph limb led to a reduction in the lateral joint space of the distal interphalangeal joint. And as a result, there was a significant difference in mediolateral balance of the distal interphalangeal joint. So going from minus 0.2 millimeters in bipodal stance to plus 0.9 millimeters. So that was roughly a 1 millimeter difference. So this was a relatively small study. However, they did use power analysis to ensure that they did have adequate numbers of horses in order to perform a statistical analysis of adequate power. Overall, it was a nice, well-designed study. Perhaps the one limitation that I thought of was that they did only acquire 1 radiograph per test horse. So it would have been nice to have had multiple radiographs of the same horse, but I understand why perhaps that was not possible. So summarizing this, if assessing balance of the distal interphalangeal joint or the hoof pastern axis, we should definitely consider how the horse was weight bearing during acquisition of the radiograph, specifically whether it was weight bearing through one limb or both forelimbs. This is also relevant for follow-up assessments of balance and hoof pastern axis. And if we're doing direct comparisons, we should be aware of the differences or similarities in stance adopted by the horse between the 2 time points. Ideally, we should ensure that the same stance is adopted by the horse. It's possible that these differences may also apply in a horse that isn't evenly weight bearing, for example, in a sedated horse where they may be weight bearing more in one limb than the other. However, this was outside the scope of this study. Just to bring back a little bit of perspective, they were relatively small differences that were created in the mediolateral balance of the distal interphalangeal joint. It was in the order of 1 millimeter. So I think it's important to be aware of the potential difference that it can make in our measurements, but also be aware of the magnitude that it's likely to create. So our next study is radiographic measurements of hoof balance are significantly influenced by a horse's stance. So this is again a very similar paper in a way, looking at the effect of horse stance. So in this study, the authors wanted to investigate the effect of stance on hoof pastern axis and distal phalanx and distal interphalangeal joint balance measurements. This was another prospective study. They had 5 standard bred horses that they used. Each of them were trimmed and balanced by the same farrier prior to being sedated for radiography. The horses are positioned with all of the limbs raised on wooden blocks with the forelimbs vertical, so the metacarpal regions were perpendicular to the ground. They acquired lateral images. For these, they centered 2 centimeters above or proximal to the solear surface of the foot, as well as the neutral stance, so that's with the metacarpal region vertical or perpendicular to the ground. The hind limbs were moved cranially in order to create a bit of angle in the metacarpal region, so the feet would be positioned behind the metacarpal region, and then the hind limbs were moved caudally so that the forelimbs were angled the other way. And they did this in the 5 horses. For dorsal palmar images, they centered 1 centimeter above the solear surface of the foot, and similarly started with a neutral stance with the metacarpal region vertical and moved the feet 2 centimeters medially until they were touching, and then 2 centimeters laterally as far as tolerated by the horse, and at each stage acquiring the radiographs. Now, they only actually did this in 1 horse. They did also look at the effect of angling the beam up to 15 degrees towards dorsomedial and dorsolaterally, again only doing in 1 horse. However, what they were doing here wasn't actually related to the stance of the horse, so I haven't discussed this any further. So for lateral medial images, the hoof pastern axis and the angle of the distal interphalangeal joint were both linearly correlated with the cranial caudal stance of the limbs. The hoof pastern axis was also significantly different when the forelimbs only were on raised blocks versus all forelimbs being placed on raised blocks. There was no effect on the angle of the solear margin of the distal phalanx. In the dorsal palmar images in the 1 horse, the medial balance of the distal phalanx did not alter depending on the width of stance. However, narrowing of the medial aspect of the distal interphalangeal joint width occurred when the horse is positioned with the limbs wide, and there was no effect of beam angulation. There are some limitations to this study. So firstly, they used quite low centering for both the lateral and dorsal palmar radiographs, and that wouldn't be a usual approach in a clinical setting. That said, it has been said that centering lower at the level of the distal phalanx is more specific or better for assessment of distal phalanx balance, which is why they chose to do this in this study. However, in a clinical situation, we would be probably centering about 1 centimeter or at the level of the coronary band in most horses. And so how these results would translate to our more typical radiographs isn't 100% clear. Further, as I mentioned, they only use 1 horse for each of the dorsal palmar image assessments, which is incredibly weak. So in conclusions, the hoof pattern axis did appear to change with stance, and that's logical. The medial lateral balance of the distal phalanx did not appear to be affected, and also the medial joint space narrowed when the horse is in wide stance. However, this was only an observation in one single horse, and so I don't think we can take anything from that and apply it to a wider population at this stage. So I think there is an argument for considering the stance of the horse when assessing or reassessing hoof pattern axis. And generally, I think, again, this brings about the fact that it is best to have a standardized protocol of positioning patients, whereby each time we take a lateral medial or dorsal palmar radiograph, the metacarpal region should be vertical or perpendicular to the ground in order to have consistency between radiographs of different horses, but also within the same horse if we're doing reassessments. However, the study is too weak to draw any conclusion regarding the dorsal palmar images. In this final study, assessing the effect of packing the sulcus on image quality in equine radiography. Now, the background to this, there is a consensus that for good radiographs of the foot, the shoes should be removed and the feet should be cleaned well. They report that it is debatable that the frog sulci should be packed. Now, they provided two references for it being of questionable benefit. The first was the Clinical Radiology or Radiography of the Horse by Butler et al. This was actually an inappropriate reference because the authors of this chapter on this book actually condone the use or they encourage the use of packing the sulci of the frog, but what they do is warn against loose packing or overpacking, which they say can cause artifacts. They did provide one other reference, and this author did warn against the fact that with packing, we can lead to decreased radiographic contrast, and that author suggests that trimming of the frog instead is preferable. So coming back to this study, the aim was to assess the benefit of packing the sulcus in the evaluation of foot anatomy. So they acquired 24 cadaver limbs and they suspended these limbs in a fixed position for the acquisition of an upright pedal image. So each of the images was acquired in exactly the same angle, and so they accounted for that potential confounding factor of different angles, which was great. Firstly, they acquired an image that was non-packed, so the sulci were not packed. And secondly, they packed the sulci with Play-Doh. However, what they didn't do is detail exactly how they did the packing, who did it, and how much they put in. So for assessment, there were 3 radiologists and 2 surgeons. They were comparing anatomical criteria between the 2 images, and they were asked to grade whether they thought there was no difference in image quality, whether the packed images were better, or whether the non-packed images were better. They also graded the quality of packing based upon the radiographs and provided an overall opinion on whether they thought packing aided versus deteriorated image quality, or whether it made no difference. Overall, the observers had a preference for the non-packed images over the packed images. Artifacts in relation to the sulcus were reported in 62 radiographs of non-packed limbs, and in the packed limbs, artifacts were present, obscuring the navicular bone in 102 and obscuring the distal phalanx or involving the distal phalanx in 91. Now, very interestingly, the packing quality was graded as poor in 1/4 of the horses and good in only 42%, so less than half had good packing quality. They assessed packing quality in relation to the quality scores, and image quality scores were inversely correlated to the scores for packing quality. I pulled out these two radiographic images, which this is figure 1 from the study, just to demonstrate that the degree of packing that they use. So this is a non-packed radiograph, and this is the radiograph of the same foot but with packing, and we can see that they've used rather a lot of packing, and we can see quite easily what they mean by packing artifacts being present in some of these feet. And I would say that based upon this, this appears to be very extensive or excessive packing. So the limitations of this study, I really question the quality of packing, and I think this is a major potential confounding factor in this study. The type of artifact was not accounted for, so they said that there were artifacts present, more so in the packed than the unpacked images. However, air shadowing from the sulci, which are unpacked, can mimic fractures, and we know that potentially packing artifacts can decrease contrast. However, the frequency of occurrence of artifact was accounted for, but not the clinical implication of these. And so decreased contrast may have been present. Is that as much of a problem as an artifact which is actually mimicking pathology? Also, it is quite possible that the decreased contrast, if that was one of the major artifacts caused by packing, could have been contributed to by the fact that I think these feet were very heavily packed with Play-Doh. Equally, it was a relatively limited assessment, so it was looking at image quality using very basic grading systems, and the ease of pathology identification, or the differentiation between pathology versus artifacts versus normal, was not assessed. And so this study did not assess the diagnostic accuracy of packed versus unpacked views. So in conclusions, the authors concluded that routine packing of the sulci is not beneficial. However, I would disagree, and I think that this study more shows that the quality of packing is potentially important, and that is what I believe to be true. The study doesn't provide strong enough evidence to support our stopping routine packing at this stage. And so, in summary, I come back to the final question: should we be doing anything differently in clinical practice? So I've just summarised each of the papers very briefly based on my personal thoughts. So for skyline views, I think the use of acquiring two separate views is not currently justified. However, I think that we should be very aware of the potential effect of angle on diagnostic accuracy. And certainly to skyline the distal aspect of the flexor cortex, using a shallower angle as well as being logical, this may have been what the study was showing, that shallower angles do better skyline the distal aspect of the flexor cortex of the navicular bone. For upright, pedal and navicular views, with modern digital systems, upright pedal views or images do appear to be able to be manipulated in order to allow good assessment of the navicular bone. However, I think the use of two views is still justified because the effect of angle was not assessed in this study, and also the effect on lesion identification or the diagnostic accuracy was not investigated either. So based on both of these views, mine and also potentially the authors, I think we can use both views for navicular assessment, so still acquire the specific navicular, upright navicular view, but also know that important information regarding the navicular bone can be got from the upright pedal image. So just because it's called the upright pedal image or view, it doesn't necessarily mean it should only be used for assessment of the distal phalanx. I think it's important that we assess the whole radiograph. For oblique or flexed oblique views, I think they are essential for evaluation of ossified ungular cartilages. So I think any horse with grade 4 or grade 5 ossified ungular cartilages, I think it is imperative that we include oblique views to assess them fully. Also, it appears that horses with a suspected fracture of the palmar process of the distal phalanx would be equal candidates for including oblique or flex oblique views, which also in my personal experience, oblique views are very useful for these potential lesions. And my personal view is that I find them very useful to include in a standard foot protocol. However, that is my personal view, and based upon this study, we can't necessarily say that they're of any technically of any additional diagnostic benefits to include as a standard view. But I would love to know what you think on the matter. For the final three ones, a unipodal stance, so with the horse just weight bearing through the one radiograph limb. This can affect the hoof pattern axis in lateral medial views, and also measurements of the distal interphalangeal joint space and distal phalanx medial lateral balance in dorsal palmar views. The stance, so whether the forelimbs are positioned cranially or caudally to the vertical, can also affect hoof pattern axis in lateral medial views. So clinically, I think we need to be aware of the potential effect of horse stance, and for acquisition of radiographs, we need to very carefully position them in a standardized way to make sure that if we're, for example, doing follow-up radiographs, we're always comparing like with like. Finally, for packing the sulci of the frog, packing materials can create artifacts which may reduce image quality. However, the effect, whether that's positive or negative of packing on the accuracy of lesion identification, is currently scientifically unknown. However, anecdotally, packing does reduce air artifacts which may mimic pathology. And my takeaway is that the quality of packing is essential. And so not putting too much in, simply putting just enough just to get rid of any air artifacts within the sulci of the frogs, and also making sure it's nice and smooth so you don't have any thumbprints within that packing material. Here are a list of references, so the 6 studies that we discussed today at the top, and 3 additional studies which I mentioned throughout.
Okay, good evening everyone. It's great to have everybody here just for the IMV Journal Club question and answer session. We're just following up to the question and answers on Laura's presentation on radiography of the equine foot earlier this week. Hopefully everybody saw it. So for those of you who don't know me, I'm Sam. I'm one of the vets here at IMV Imaging. I'm delighted to welcome my colleague Laura, who gave the presentation earlier this week, and also Hannah, who's one of the vets here at IMV as well, working in with the account managers too. So we've had loads of great questions on all the kind of radiography papers. It was a veritable plethora of papers even, because there were 6 of them, and we've divided this journal club into 2 parts. So for part 1, we were focusing on radiography, so radiography of the equine foot as well. So I'll fire away with the first question we got sent in after the presentation. So that was, do you routinely stand horses on 4 blocks before taking balance radiographs? The person who posted this question mentioned that they usually stand either both front or both hind limbs on blocks, but never both. And was that something that they should be reviewing, or are they consistent using their positioning in that way as well? So what do we think about that, kind of positioning the legs up on blocks?
I mean, I'm very similar. I would tend to either do both front feet or both hind feet. I've never done all 4 feet before. And yeah, like the last comment, I think so long as we're consistent, most of the time it's ourselves doing the repeat radiographs or someone in the practice, and presuming we use the same protocol, then they should be comparable. And that's the main thing, is being comparable within yourself and your colleagues. Obviously, I think the tricky situation comes about is if you have someone who positions on blocks and takes radiographs, and then you do it differently, and then you're comparing 2 different techniques. But also at the same time, I think in the grand scheme of things, how much of a difference does it make? I mean, there is a significant difference shown, or there was in the study, and they used 6 centimeter blocks. So probably if you use bigger blocks, it may make a bigger difference. But in the grand scheme of things, does it change what you're going to do clinically? Maybe, maybe not. But I personally think consistency is the main thing.
I would absolutely agree. I'm saying in practice, I personally have not put all 4 feet on blocks. I mean, sometimes it's fun enough trying to get 2, both the forelimbs or the hind limbs on the same block. But I'd absolutely echo it. I know there was a vast difference in the way that our kind of vet team kind of approached radiography as a practice, and therefore that consistency is key. And getting kind of a protocol in place, and it sounds very kind of like, you know, structured a protocol, but I think it is very important, so you then effectively evidence-based kind of why you're working, how you're working, and compare like with like.
Yeah, I think that's a good point. Save your sanity. Sometimes getting them on 2 blocks is enough.
It's always that last second just as you're about to take the shot.
Of course, yeah.
Yeah, move or something changes. Great, that's some great answer there. We'll move on to the next one from there, just going away from the positioning slightly. One of the respondents asked, do horses need any sedation for acquiring, they specifically mentioned shallower views, so they're probably just mentioning, do they need sedation while they acquire those slightly different angled views as well? So what do we think about that?
I would say it's actually more on kind of the taking kind of a step back, actually taking that word shallower out of the question. Like the horse itself doesn't know, you know, what kind of angle you're kind of putting your generator at and getting positioned in, and therefore, you know, ideally, you know, sedation, adequate restraint, be that kind of chemical in that or physical, is always important, because any kind of movement that you get there is going to reflect, and the interpretation of your image is only as good as the image that you're acquiring. So you want to optimize that as best you can. So I would say personally, and there is a bit of personal preference here, I have tried to radiograph in very stoic animals without sedation, and I've found generally the image quality hasn't been as good. So I would probably err more on the, even if it is a light sedation of some kind, so you can get that shot first time as well, because you also, from like a health and safety, you don't want to be taking any more radiographic shots than you have to, essentially.
Yeah, I think that's a really good point, is that you have to be careful with how much of radiation exposure we're getting in these situations. But then we've all probably been in that situation where you've got the most sort of docile horse in the world that lets you position it on blocks and sort of stands quite nicely for you to take the views. But then equally, you've also got some pretty expensive equipment in and around their feet as well. So the last thing you want is a plate stood on, or somebody hurt or ending up taking a lot more radiographs, especially if you're out in the field and you've got, in some situations, a limited number of plates that you're going to be able to take if you've got certain systems with you. So all these things is this stuff you'd have to maybe think about and use your judgment on.
Agreed.
Yeah, especially for these views that were being asked about. It's a skyline view. You've got the generator right underneath the horse. Sometimes you have to have it so high, you've got to be really careful not to touch its abdomen. And if you do, then they don't always like that. So I think, I mean, I'm a massive fan of sedation. I think sedation makes radiography so much easier and makes your images so much better. A lot of people, I think, like out in practice, you feel pressure from, for example, the owners to not sedate, and they said, oh, you know, another vet came out and did it without sedation. Are you saying you're not as good a vet? But I think it's really important to know that actually it's by sedating you take much better images. So trying not to succumb to that pressure. I mean, I would sedate routinely, pretty much for everything.
Definitely, and I think you know, there is a definite health and safety element as well. You know, I've tried to do certain kind of imaging procedures without sedation, and actually you end up with wind up anyway. You end up having to sedate them in the end. You actually giving them more sedation than you need, and just preparation with imaging generally is the key. You know, it's not sexy, it's not cool, but like, you know, making sure everything's prepped right, making sure the environment's correct, the patient's right, that you know, you're taking your time to set up the equipment properly. So then when you have that second to get that shot, you get that shot the first go, and it's as beautiful as it can be. And that's going to add the most to your diagnostic workup.
Yeah. Right. Okay. So next question we had in was somebody wondering about whether there was a significant difference noted between standing obliques and flexed obliques of the ungular cartilage. So this is obviously to achieve views of the ungular cartilages. They would mention that they wouldn't uncommonly take a standing 45-degree oblique view of the feet to assess collateral ligament origin and insertion. So yeah, really coming back to it, do we feel there's a difference between the standing and flexed obliques when looking at those areas?
Well, in the study, we didn't assess flexed versus weight-bearing obliques, simply because practice protocol, we acquired flexed images over weight-bearing ones. And so it was a retrospective study, that was what was available. So we didn't have any weight-bearing ones. I'll actually just do a little bit of a screen share here. Can you see my screen now?
Okay. Yep. Yeah, it's up there.
So these are the two different radiographic views. So on the left we have, this is a flexed oblique. This is the one that we used in the study, and on the right is it's not the greatest quality one, I'm afraid. It was one that was sent to me as a JPEG with a referral, so it's not the best. But please forgive the awful pixelation. So this is the weight bearing one. This is just my personal experience, but I find that when looking at the flexed ones, I can much better assess the periarticular regions of the proximal and the distal interphalangeal joints compared to weight bearing. And again, aside from the quality of this JPEG image, we can see there's a lot more superimposition in the weight bearing one. And so assessing those regions for subtle changes and small periarticular modeling or osteophytes is, I find, more difficult in a weight bearing than the flexed. The one disadvantage of getting a flex one is that it's a little bit more tricky. So these flex ones are required in a clinic, and for foot radiography we would always have 4 people. So there would be one person designated flexing the limb, someone plating, someone holding the horse, someone acquiring the radiograph. You don't often have that luxury. So it kind of depends on who you have helping handler wise and how good they are at multitasking. It is possible to support the limb and hold the plate, but again, that's handler dependent and also horse dependent, because often you need someone to hang on to that leg even in a well sedated horse. So pros and cons, but personally I prefer the flexed one, but a lot of really useful information does come about from the weight bearing one as well, so it's still beneficial to acquire it, definitely.
Okay, because that kind of partly leads us on to the next one, where somebody put a question just again focusing on the flexed oblique views of the foot, again stating that sort of obviously they should be done when they're suspecting certain problems, but maybe kind of questioning how useful they are in a sort of more routine way for low-grade lamenesses, and sort of justifying the expense of those extra kind of views really as well. So, I mean, in your opinion, is that something you would want to have in every routine exam, or is it something that you feel lends itself more to specific kind of sort of, I suppose, clinical suspicions of problems?
I would have it in all exams. So I myself consider it as a standard radiograph to acquire, and so I would always acquire it. The only exception would be if I was doing a very limited foot series, for example, horse with laminitis. I want to know what the distal phalanx is doing, or radiography to assist with farriery, for example. I'll just share this screen again. So the regions that I feel it really helps with would be, so as well as the periarticular margins on the dorsomedial, dorsolateral, plantar or palmar medial and palmar lateral aspects of the joints, it's really great for assessing the medial and lateral eminences on the middle phalanx, and this is the origin of the collateral ligament of the distal interphalangeal or DIP joint. So it's really great for evaluating that. Equally, the extensor process of the distal phalanx, I really like obliques for evaluating that. You can see quite a lot in lateral medials and dorsopalmar views. Sometimes, though, if there's like a little sort of discrete bit of modelling, I find it skylines really nicely on these. Also, this region here on the distal phalanx, so it is possible sometimes to see new bone formation on the dorsomedial and dorsolateral aspects of the dorsal cortex of the distal phalanx, often in association with laminar pathology. And so this is something you would only, I feel, see in these views. Again, this is just personal experience. But you'd often see that in horses with perhaps atypical laminitis or subclinical or chronic laminitis. So I think this is a predilection site for modelling, and certainly it's also something you'll see on MRI as well. So you'll often find horses with laminar pathology that perhaps may or may not have had subtle radiographic signs. There's this region on the dorsal medial and dorsolateral aspects where there tends to be the greatest reaction of the laminae. So I think it's an important site to evaluate, and I think especially that laminitis, I think, is something or atypical or subclinical laminitis, something we don't, or we underdiagnose quite a lot in sports and leisure horses. So again, I think it's important to look in that region, but also, as demonstrated by previous studies, the palmar process is really important, the base of any ossification of the ungular cartilages. And also it's quite nice, it skylines the median lateral proximal aspects of the navicular bone. And it's usually with foot radiographs, we'll get the sort of the distal 1/2 or possibly 2/3 of the proximal phalanx. And again, the palmar medial and lateral aspects are where the oblique sesamoidean ligaments attach. And again, it's possible to see modelling in that region, which you otherwise wouldn't pick up. So for me, I find a lot of potential information would be got from these flexed oblique or weight-bearing oblique views. So those are the main reasons why I personally always include them. But of course, it is 2 extra radiographs, extra time, extra cost. But for a lot of horses with subtle lameness, I would definitely include these.
And I must say, like when I was in practice, like it wasn't a standard view that we kind of added in there, exactly due to kind of think how the question kind of emphasizes, like due to cost and things like that. I think it's very interesting, you know, how kind of technology's kind of moved on, that maybe, you know, now with those subtler lamenesses, they are added in as standard. You know, you can change that protocol like at any point, and actually with that kind of therefore kind of emphasize that maybe it should be part of every kind of foot series.
Yeah, I don't think anywhere says, you know, it's
yeah,
part of the foot protocol.
Yeah, no, but it's also like, you know, we learn, we're always learning as a science industry. Like if there's evidence we should be adding them in, we can always change.
Yeah, well, it's good to know what's around there.
And one of the questions we got while we've been discussing this kind of view is just somebody asked about just the kind of the technique for achieving it as well. So I don't know if you want to give a kind of a brief run through and how you get that view.
Yeah, so I've got some helpful diagrams again. This is the benefit of collecting all the questions in advance, so you can get all these nice slides ready. So the technique, well, there's two different views that you can acquire, I should say first. There's a 60 degree and a 45 degrees. So for sports and leisure horses, general horses, I tend to acquire a 60 degree oblique, just because it skylines the margins of the distal and proximal interphalangeal joints a little bit better than a 45. So the 45 is better if you're looking for palmar process fracture. So the technique in this one, this is a photograph of a horse, and we're acquiring a flexed oblique for this one. So we have one person who's holding the limb in flexion, the toes supported by this modified wooden support here. And then for the 60 degrees, it's 60 degrees from the dorsal aspect. So if you imagine that you are coming from doing almost like a dorsal palmar view, moving 60 degrees towards the lateral, and then that's the right angle. Otherwise, it'd be 45 degrees, either from the lateral or dorsal positions. And then the plate itself is behind the foot at the same angle. So you always want the generator and the plate essentially to be parallel to each other. So they're almost looking at each other. So that just means that the plate is going to be perpendicular to the beam. And this diagram here, just the top right hand side, I think is also potentially quite a nice way to visualize what we're doing with the angle. I find sometimes it's quite easy to see a 60 degree angle and you think, okay, 60 degrees from where and to where. So 60 degrees from the dorsal or dorsal palmar sort of transection there. And then with regards to centering, you want to be centering at the level of the dorsal coronary band. So that's just demonstrated by this image here, which is fine if you're coming from this angle, like in this image. So this is, I think this looks like the left limb of a horse. So this is a dorsal, actually, I think it's the right. I think this is the right limb of a horse. So this is a dorsolateral oblique. If you were to do a dorsal medial oblique, I find it sometimes easier to come from the palmar aspect rather than coming from the dorsal aspect. Similarly to if you're doing like a hock or something, because then you're not crossing the horse, it gives you better visualization. If you do that, it's really easy to center too high and cut off the toe. So just try to remember that you're centering at the dorsal aspect of the coronary band, which by the time you come round and you'll be centering pretty much on the frog or somewhere on the lower heels, which feels a bit odd, but it's right. But that would probably be a little bit easier in a weight-bearing limb because it's level. So I hope that makes sense.
Yeah, no, I think that makes sense. It's really helpful having the diagram to be able to see it and just to help visualize it as well, really too. Great. And so we had another question coming after that, was just giving advice about exposure settings to view the dorsal hoof wall. So I don't know if we have any thoughts on just sort of exposure settings for looking at that that part of the hoof anatomy.
Yeah, well, the main thing is that you want to be able to visualize the hoof wall, so you don't want to overexpose and then lose all that nice soft tissue information. So the things we need to consider would be the KV and the MAS, and also the film focal distance, or how far away the generator is from the plate. So the MAS is essentially how much radiation the generator is producing, and the KV we can think about is how much penetration that said amount of radiation achieves going through the horse, in this case the foot. So you can potentially burn out the hoof wall by either having too much penetration because you've got too high a KV, or having too high an MAS. So it kind of depends on the problem. If you find you're taking a radiograph and you can't see the hoof wall, it might take a little bit of an experimentation. There are ways you can find out, but sometimes it can be a little bit difficult to tell the difference. As a general rule, though, I find that having too high a KV is perhaps, I think, a more common issue than having too high an MAS value. But again, it could potentially be either. And then also the film focal distance. So for every sort of 10 centimeters you get closer to the foot and therefore the plate, you're essentially increasing the amount of radiation quite significantly. So that can also have quite a surprisingly large impact on image quality. So I think it's just a case of being critical of your exposure values, making sure that you are getting good soft tissue contrast. And I think the other thing perhaps to consider is also post-processing as well, because I think that can make a really big difference, because you want to take the best quality image to start with getting the ideal KV and MAS, but then especially with these new systems, there's so much you can do post-processing wise. You can, I think in my experience, make it disappear when you have got the information, and you can try and make things better. But I think starting with good exposure values is definitely the best, like the absolute best way to go about it.
I completely agree. And with your exposures as well, like your MAS, the amount of radiation there, the amount of information you're getting there, if your MAS is too low and you aren't getting that information to the plate in the first place, no matter how much you post-process it, you're never going to get that information. And I know there is often a lot of talk about newer systems and like really like DRs systems, like how they can, there's all this post-processing, and that's really great, but it doesn't take away the importance of like what Laura, what you just said about kind of like getting the right exposure in the first place. It definitely needs the right information getting to the plate for us to be able to kind of manipulate it to the best image it can be.
Yeah, I think it's coming back to the settings. It sort of shows the importance of keeping your kind of exposure records and kind of using them to kind of form the basis of a kind of charts for these views for different sizes. Because if you're not kind of recording your exposures or paying attention to what you're using, you're going to end up taking a lot of X-rays that are just going to be poorer in quality as well. Because at the end of the day, the post stuff, as you've said, can only do so much, can't it, as well?
And as you say, like critically analysing your own X-rays, like saying like, yeah, okay, you know, on that particular kind of, you know, that shy horse, that was a really good exposure. Oh, but the miniature everyone got completely wrong. But, you know, next time you can change it. If you don't note it down in the first place, there's nothing wrong with getting it wrong, as long as you're then changing and adapting your way of getting those images in the future. Like,
yeah, getting the right exposure settings and the right post-processing is hard work. You've got to dedicate quite a lot of time to do it, but once you're there, it's so worth it. That's the thing. You've got to go for it, I think.
Excellent, excellent. So just moving on to the next kind of question, you just had a comment from one respondent who's saying their practice routinely only uses a single upright view, but as Laura we discussed during the presentation, they were maybe risking missing information, specifically referencing kind of navicular fragments, and they were just sort of saying it would be very interesting to see that the particular study that mentioned it repeated using the shallower angles with a sort of MRI control to see how useful it was.
Yeah, I think that's a really interesting comment, and I think it was a very interesting study, because they did show that using post-processing and the facilities that you have with what we now have with DR systems, you can do manipulation and achieve things that we weren't able to previously with regards to viewing the navicular bone on an upright pedal view. Although from a purely clinical and practical perspective, I don't think we can necessarily say that image quality is just as good or better with an upright pedal view that can be manipulated. I think this listener is entirely right. We need to know whether we can see all of the lesions and differentiate them from artifacts. So absolutely, I think it would be so interesting to repeat the study and investigate the use of different angles with MRI with regards to the upright pedal, upright navicular views. But I think it just shows how much radiography has come on and how much can now be done with post-processing. But I think the question is, you know, is it all about post-processing and image contrast, which is what the study primarily looked at, and image quality. I think the one thing that study didn't look at that would be essential would be looking at the different positions or the different angles for pedal versus upright navicular shots.
Excellent. Good. Well, that's a good run through of all the questions that we had in. Thank you everybody for submitting them and watching tonight. And that's a good bit of time now, because we've gone to a good 40 minutes there. So thank you everybody for joining us tonight for this Q&A session. It was great to have everyone's questions. I hope everyone enjoyed the presentation. Stay tuned for next week, because part 2 of the Journal Club is coming. So this time it's more looking at the radiological aspects of kind of equine foot radiography as well. So there'll be another sort of lot of papers discussed, and we're going to do the same next week as well, where we have the presentation and the Q&A kind of coming as a follow-up a few days later. So keep an eye on our Facebook groups or on your email as well. If anybody does have any questions in the meantime, we're always happy to hear from everybody, and you can get in touch via the hello@imv-imaging.com email address as well. So as I said, just finally to say thank you Laura, and thank you Hannah for tonight, and we will see everybody later, hopefully next week. Bye bye.